So let me welcome Kathleen and Jason and start off with talking a little bit about that first question of what are the key design elements you believe from your experience that are necessary to create a robust and engaged network of organizations. Kathleen and Jason.
Jason, do you want to start? You were so cut off on our practice model that you must be able to start. Yeah.
Yeah. So we're gonna get away from the intervention for a second, and we're gonna think about multi-sector interorganizational collaboration as a start, right? And the idea, and I think that was one of our main, and we've put that into a term of ecosystems, right? But the idea, and I think that was one of the lessons that came out of our RCT, is that no matter how good your intervention is, it can't work in isolation. So I think we're gonna talk about broad community partnership here, right? And Kathleen, I think it speaks to, and thinking about the Pathways Hub model and how, we certainly hybridized a lot of the best models that are out there. But I think the idea of a convening organization, about a group within the community working to kind of bring folks together. And we talk about by design and some of the work of the coalition, certainly even from the board perspective. I think it might be helpful to start from there on how having an inclusive board at the community level, including those voices and consumers as well, kind of sets the stage for partnership. And then we kind of build from there. I think very early on, we're very intentional about bringing folks together, whether it was primary care providers around a breakfast table, and then branching out and then bringing organizations together. So I think that might be a place to start, and then we can obviously move down to the technical level. But I see that as one of the foundational components, certainly of our approach of building and fostering those relationships across the community.
Do you have a process for screening, inviting in, engaging people into the network? If I'm an organization just wants to be part of your work, are there parameters for that?
I just want to say we are we have a really weighty membership fee of $50, which we waive regularly. So no, we have a lot of members, and then the board members are chosen from members, but we have membership classes within our board. So, which we're actually thinking about changing because they are a little bit healthcare focused, and we want them to be a little bit broader. Although they were always broad, they always included partner organizations, community-led organizations. So that can be anything from AARP, right? So community-driven or community member-driven organizations to a Faith in New Jersey organization. But then we have, Jason was mentioning, our community advisory committee started out as a council, but they're now a committee of our board, and they are residents in Camden or the Camden region. Some of them are graduates of our program, and some of them are actually residents who are, a former social worker from one of our anchor hospitals who's a resident who's also grew up in Camden. So, and the chair and co-chair of that are trustees of the organization. So very much it's just like, are you interested in these issues? It's a pretty open process.
And can you speak a little bit to governance?
To governance at the board level, or governance out in the, so governance at the board level is very much, it's a membership board. So that means that it's hard. I just want to say, I was at Children's Hospital Philadelphia, and my last couple of years there, I helped the CEO run the board. It's a very different board. It's not 14 people where 12 of them don't do healthcare, right? And they're just there because they care about this community issue. It's a board with people we work with in the community. We compete with them sometimes on grants. Right? We have issues with each other because that's what you do when you work closely with people. So we're not the boss of everybody. We're not like it's not like we are the central organizing leader, but we act in sort of coalition. And so we convene a lot of meetings and we syndicate a lot of best practice models so that, Jason talked about our core model. We have a model right now, which is a sort of derived from that, but focused specifically on the ER and mental health. And we actually go out to our partners and talk with them as we're fundraising to sort of try to do that and then figure out who we're going to work with. So it's a lot of consensus building and a lot of collaboration.
Rachel, do you want to ask your question?
Yeah, I had thought, Kathleen, in the earlier comments, you mentioned that the public health department is coming on to the coalition. Did I hear that correctly or
You
not?
did, yeah.
Okay.
I have to say the coalition in the beginning was very healthcare, and I mean that like capital H, capital C focused. And we've really, as Jason is now talking about I'd say that we've become much more focused, and really through our intervention that we learned that each time we hit a barrier, it was, we had to build out and outside of healthcare. Yeah,
we're excited to see the public health departments really take on a much larger role in the pandemic and then now beyond. I think it's an exciting, development. Could you ever see them being a convener?
Yeah, absolutely. I mean, they're not staffed to do that right now. Right. I mean, the story of our public health department in Camden is I tried for about 1.5 years to have them join our health information exchange, and we charge organizations like them a whopping $8,000 to have total access. I mean, it's just like I keep saying, like, don't believe the IT vendors, like this is cheap. But their county commissioners voted down them joining our HIE in January 2020. On March 20th, I got a call from the second person in command of the Camden County saying, we have our tails between our legs. We have to get on their HIE. What can you do? And so we got them literally on the HIE within days. So I think the pandemic has also sort of like awakened a lot of people to the infrastructure that's needed for some of this.
Right.
Yeah.
Kathleen, you're also, and you all mentioned this, you're doing work in other parts of the country. I know about some of the work you're doing in California. You've brought to the table the criminal justice sector, as well as some other sectors that don't usually see themselves in the health space. Are there challenges there with bringing in other sectors who normally aren't in the health space?
Jason, if you want to talk a little bit about our jail work and how that started in Camden, and then some of the work out in Lake County.
Sure. And so just as a Rachel, to your point, I just want to on the opportunities for state, county, and local health departments. We've heard, as especially with a lot of resources being pushed out through, as like we think about ARPA, an administrative preparedness issue, the ability to kind of manage everything that's happening in organizations, and it's like that have been really underfunded, chronically underfunded and resourced for a while, and thinking about ways that we can support from as community-based organizations. So I think there's a lot of promise there. From the national perspective, we'll pivot there. The county departments of health leading some of these initiatives, being uniquely situated where capacity is growing, right, and has accelerated throughout the pandemic. So there is some promise there, and we're working on some of our ecosystem projects directly with county departments of public health on focusing on some of their vulnerable marginalized populations and working with multi-sector players. So it's developing. That's great to see. As far as I want to get back to that question about criminal justice involved populations, this is definitely a trend that we're seeing. So in Camden, if we go back 10 years ago, when someone would fall off, we had our health information exchange, we're following folks, and then their utilization falls off, right? Where are they? And it turns out a lot of times they would go into the county jail, and we wouldn't have any communication what's happening with them, right? They would have complex health needs, right? So there wasn't information being shared. It was kind of like a black box. And the providers within the county facility were kind of working blind as well. So I think slowly through our projects, we started to open up, one, the relationship, and then I want to get at this certainly came out with our organization and throughout COVID, is the trust and accountability as a convener, as we're seeing in the community, right? And Kathleen, you can certainly speak to this. I think it's worth mentioning. It ties to Karen's model, how we were seen as that group within the community and implementing COVID testing, vaccination campaigns, working in the community. So that definitely, I wanted to spotlight that. But so we're seeing a trend now around involving criminal justice populations. The one thing that's jumping up for me is are the data sharing challenges that are seen across the country. How do we share data and sensitive and protected data with institutions that haven't been set up to do this? So a lot of it is very manual right now. We're working with in South Carolina, a nonprofit that's based inside several prisons. And their big issue is, how do we share the data and the needs of the folks that are inside these prisons with the community-based organizations that are focusing on reentry? So that comes up as something consistent. I think, that we're working with from a technical assistance perspective. And Kathleen, it gets into certainly we're seeing this with our health information exchange. Not only the technical platforms to do this, but the legal arrangements that need to be hurdled. And compliance issues with working with institutions that aren't used to sharing their data across sectors.
We're going to be spending a little bit more time on the data issues on the third question. I wonder if you could speak a little bit about any challenges that you have with organizations within your coalition.
And I saw Lisa had her hand up, so I just didn't know if
I
she
missed
had
that.
Yeah.
Lisa.
Well, I'm also interested in hearing Diana's question, but I wanted to ask a couple things. Do you think of the network as a Camden-wide network, or does it vary from community or neighborhood to neighborhood based on their needs and the availability of services, and sort of how do you manage that? And then I also was wondering, to what extent, the way the model's funded, is it driven by populations that other people are picking as high value, as opposed to a broader community-based need, or how that works? And is there a differentiation in how that's funded?
So I'll just say that we to your first question, we think sort of regionally. The healthcare is very regional. It's not really Camden City. We started in Camden City, but actually some people go over to Philadelphia, some people go county to county. And so we think of the ecosystem as sort of regional, to be honest. And I think that's the way the national team will go in as well. But depending on the issue, we actually get down to the neighborhood level. So in Camden, the against our advice, by the way, the two major hospitals put a Camden COVID test site in a place that we said, and our community advisory committee said, was a terrible place to put it. They put it there, they put 40 personnel there, and it was a failure, which we were able to talk with them about. And then with our data, we were able to actually get granular to the neighborhood level and put COVID pop-up test sites in neighborhood-based locations. So what I'm saying is, we think of it regionally, but you got to get really detailed sometimes depending on the issue. That's the first thing. And the thing about the money, we're like it's like sometimes we're funded by MCOs. Like we're not Medicaid or Medicare funded. That's important for people to understand. We're sort of we see ourselves as a syndication shop on the ground. So we're constantly looking for funds that are flexible enough so we don't have to get, so that we can be a little bit more nimble. But something like the Pathways model that actually has a sort of per member kind of model, that's sort of like a fantasy, like that would be great. But you don't get that under Medicaid or Medicare. So that we get that more from combining foundation dollars with MCO dollars, with, you know, membership fees that the hospitals give us, kind of thing. So we sort of put all that together. Jason, I don't know if you have anything to add to that.
I mean, our
Standardized yes, we
experience with
do.
the managed care organizations is they define this very specific population that they want us to reach out to and
Yep.
find services for, which are high needs, you know, no problem. They're high needs populations. But it's driven by their economics, not by like a community need.
Yeah, that's why we do a lot of work. I mean, we sometimes are not working with any managed care organizations because they're just in a moment where they're not being flexible, or like
Right.
right now, we're only working with 2 of the 5 in New Jersey.
Okay.
So it just depends. But I should just say that we were able to get ourselves designated as a regional health hub in New Jersey, which comes with Medicaid funding for our organization to actually do data convening and advice to the state.
Huh.
And so that's a really important part of our funding model. And it allows us to use other funds we get to like underwrite care management.
Wow.
Yeah.
Interesting.
And Lisa,
Sorry, back to you, Diane.
no, Lisa, I just want to add to so in our national work, some of the, I think, more enlightened payers are taking unrestricted funds and building, and instead of building like internal care management capacity, they're pushing that out to organizations that have social determinant interventions, right? For them to develop their programming. And so and we've advocated, that's great. You need to push money out of the plan to develop these organizations and these networks. You can support them with either embedding staff downstream, like in practices, with your data and analytics, which you have all this claim-based data that's there to help them prioritize populations. But, you know, liberating that money out of the, you know, if we can get it out, and to Kathleen's point, in more with flexibility, so they can support paying folks, you know, sustainably, training their workforce and providing these services. Again, so I'm seeing movement like that nationally with some payers, not all of them, right? But certainly the ones that are stand out to us, and use the money as kind of a, for development of these networks, which they know, which I think there's a growing awareness, like these community-based networks are absolutely essential if they're going to impact the social determinants of health.
Right. I just feel like we're financially forced to approach this from the high utilizers down, and we're not even close to getting. I mean, it'd be interested to see in terms of 211 and what they're getting into it and how that's funded. But, you know, we've had no choice really, or in early days, but to take this from the high utilizer approach where we can get funded, as opposed to going to the 33 hardest hit communities in New York City and saying, you know, can we build community infrastructure here? Because that's not funded.
I think we're sorry, Diana.
No, go ahead.
We've been able to supplement. We have an Accountable Health Communities grant, which has allowed us to go much more upstream with screeners and navigators. And that's been really helpful. So that's one thing we've done. You know, some of the other stuff that we've done is really just work on training and building out some of our building out some of our sort of revenue generating components that can subsidize some of our work to be more flexible. I don't know what else to say about that, but when I was at the CHOP Research Institute, we had a hard time getting family planning research dollars. So we subsidized it through the work that we could get funding for. And so partly I see some of our care management function as, you know, subsidizing part of it until we're able to. So
that's what we're trying to figure out.
Yeah. So
option,
yeah, I'd say just another key design element just to make sure is that we have an approach to patients, which we call Coach, which is a manual that we use. It's manualized, basically approach to our interactions. But I would say that the Coach approach, and Jason could say more about this because he trains on it, is the way we sort of approach systems as well. it's extremely like relationship focused. It's really, bakes in motivational interviewing techniques and it's just how we sort of approach everything, but we have manualized it because we need to make sure that our staff are trained in that we have a sort of common language that we use, and that our client interactions are guided by that. So Jason, I don't know if you want to add anything to that, but that's really, oh, there he goes. Yep.
Yeah, I'm just adding that relationship-based approach, I think, starts from the organizational level and then goes down, right, to how we're engaging participants, right? So yeah, a lot of the work, for example, that we do with building coalitions around the country, even locally, is based on the relationships that we have, right? And the trust and accountability that's baked in. Also the idea that you're going to design something that's fit to context, as opposed to landing something on an individual and on an organization or collaboration, which from an implementation perspective makes a lot of sense. So I outline coach here, but we apply this to patients, and I love how Kathleen links to, that's the work that happens with partners as well. Fosters trust, right? There's a lot of listening, and just good design. There's more info there. Lisa, I want to make sure that I'm getting to, you had multiple questions, and Diana.
I did. This is good. We may need to move to the next topic because.
Well, I'm going to suggest that we continue this discussion, and we're focused on key design elements, but we're also getting into some of the operational issues.
Yeah.
Somebody posted about having a screening tool that's used across sites, it might be helpful to hear where there are barriers to getting people to adopt the same screening tool. But I wanted to start with asking Ngozi, because we're trying to capture what does everybody see as sort of some key takeaways, learnings. Ngozi, do you want to share what you posted in the chat?
Yes, I have a question first for the Camden Hub. How do they express value for the intelligence of community-based partners that are engaged, the service providers, and for encouraging client participation in the process? That is very important from my perspective, having been in this community engagement and CBO work for 35 years. So that's the first thing I want to ask, if they could give an answer. And then I'll go into this SCA model, which is, I don't know if you want to answer that before I go into this, the socio-ecological model.
Sure. So we, as I said, we have a community advisory committee, which is really engaged in our work on the ground, as well as our work that we do in other places. And just this morning, I wish I could show you a flyer that one of our community advisory committees members sent, because he is actually out ahead of us. We are helping next week with one of the things that we realized is that there are 11 pharmacies in Camden City. 7 of them are national chains, 4 of them are locally owned. 5 of the 7 national chains are not doing vaccinations in Camden City. 3 of the 4 local pharmacies want to do vaccinations, but they've had a harder time getting them. So we've been trying to help them, right? So one way we engage our local partners is to get very, very local, right? Find out which pharmacies do you use? How can we help them? So next week we're doing an event, and we are loaning some of our nurses to do vaccines with the local community-owned pharmacy. And our community advisory chair just sent us a flyer that he's already done on the event. And the way I just want to say is that I don't F with people's motivation. I try not to. I mean, sometimes I do, Jason can tell you, but like their flyer is going to be the flyer we use, because that's what they put together. And so, I mean, they are so engaged in our work that they know what we're doing next week. And so we just have made a commitment to really involve them. They're part of all of my board meetings. The chair and co-chair are one of them's a graduate of our program. Another is part of our Housing First program. They are very, as I say, they're my boss, right? So I answer to them and 26 other trustees. And so that's part of how we do it. And Jason, I know, you could talk about, I guess, the consumer scholars and the way that we have embedded that in some of our national work as well.
Mm-hmm. Yeah, and I just appreciate the question, Ngozi. Staying really grounded in this and integrating it into the values and missions of our organizations, coalition, and also into the leadership circles, right? Like holding board seats, and that inclusiveness is really, really important. And I tried to lead with that in the presentation, the idea that when you're really centering folks, and also I think it speaks to seeing folks as equals, right? Like that we're working alongside you all, right? We're allies, we're co-conspirators, right? We're leveraging our privilege and resources to support these mutually agreed upon goals. So I think it's smart to really ground and root ourselves in that. And that isn't necessarily seen across, as Kathleen mentioned, the traditional healthcare delivery space, and has taken a lot of work internally. And we don't always get it right, I will say that, right? And trying to do this, like, sometimes we can be, are we giving lip service to this? What does it mean to meaningfully include our community and to find ways to include their voices, their leadership, and to identify development opportunities as well. And this is where Kathleen was mentioning, we've started a Consumer Voices Bureau, a National Consumer Scholars Program that we're kicking off. We have applications open for that, to bring individuals with lived experience from across the country together to develop skills so they can lead these initiatives, right? So it's a work in progress.
And then Ngozi, I'm going to suggest that we capture your comment from the chat because we've got a couple people with hands up, but thank you for that question. And I'll go to Shoshana.
Hi, thanks. Thanks everyone for sharing. This is such a great discussion in the group and in the larger discussion that we were having earlier. I just want a couple of things. The flyer sounds great. The scholar program sounds great. The community advisory group sounds great. We all do that work here in New York City and have been forever. So none of it's new. I respect it. I'm glad you guys are speaking the language. This group, look at this call. This call is still really white. There's no melanin on here. Ngozi, you're representing, it's still a disaster as far as leadership circles go. And that's true for, all of our organizations. Like until we replace ourselves, we're still white privilege leading these conversations. And I have to call that out because I can't stand like the pretense, not that you all are bringing that, but like, it's just in our world. Like, it's just, I've got to call it out. Okay. So that's one thing. The second thing is in terms of operationalizing, so in New York City, our community health workers are still on NowPal and Bertha and Unite Us. Okay. That's a disaster for us. None of them work. None of them for what we need community health workers to be able to do for loop closing. So I know it's early days and we want to get there, but like we really have to kind of work with our state here and learn from 211 and Camden and Pathways and everybody and do something so that we have interoperability and standardization. I saw Val Gray was on the call. I know we have HIE kind of efforts going on as well. Lisa like knows my shtick. None of this is new, but like we really have to, I really am 11 and a half years into leading AirNYC, and like we've got to kind of move to some kind of standardization if we're serious about loop closing, standardization, true diversity in leadership, and reimbursement pathways that are real. Because what we have now, the best case scenario is the pipes for these various platforms work, but they're bridged to nowhere if the CBOs don't have the resources to deliver on the unit of care that is requested and desired and needed in the community. And so, great, we're fixing the pipes, and that's wonderful, necessary, not sufficient. Like in the least, we don't, PHS and AirNYC helped to try to lift up Unite Us because it was accessible to CBOs, not because not because we don't love NowPal, Rachel, but like, how do we get in on that from a community rooted perspective? So like, we've got to sort of solve for some of these things. Otherwise, it's just barrier, barrier, barrier everywhere we turn, and we're just adding in work. And the last thing on interoperability, what Jason mentioned as far as MCOs pushing out the dollar so that CBOs can, so the work can be outsourced. I think that's the right trend and excellent. But those MCOs also require their own platforms, and as do the healthcare delivery system. So RNYC continues to work across, as a community rooted group, all of these different systems on the provider side, the payer side, and the social care side. And it's truly untenable. And we also, we're admiring the problem, and we got to move. I want to work with everyone on this call and beyond to move past admiring the problem. That's it. Sorry, I get very riled up.
No, I love a riled up person. I just want to say that we've been using Aunt Bertha for 5 or 6 years, and I said to them, number one thing for me is interoperability with Unite Us and NowPow. They are both really good platforms. They are shit to us if they don't work together, right? Number one. Number two for me is HIE integration, because I can't do anything unless these things work together. So, and I will pay you for that. And I didn't have money to pay you for that, and I'll pay you for that, right? So that's really, really important. And, one of the things, the Camden Coalition, I came 3 years ago from CHOP. We are better than the health system that I was in terms of lifting up people who come from Camden who work in our organization. But we did an across the board. Look at anyone that's been here for 5 years who hasn't been promoted, and why not? White, black, brown, whatever. And it's a little bit like, have we given people the skills? Have we not told people? What's the issue here? Why do I have nurses who have never been promoted, right? Why do I have community health workers who actually don't want to be promoted? Why don't they want to be converted? Can we at least ask that? Can we understand that? So these things are very hard, but we are a little bit we are at least trying to say, we have to ask the question. If we have a nurse who then goes and works a night shift, because that seems easier than being a leader here, why does that seem easier than being a leader here? Then we have to understand that. So just a little bit on that.
If I can just add, Shoshana, I think the most, and maybe I'm wrong, but I see more and more funders saying they're only going to fund Black-led or person of color-led organizations. I think that is the most compelling change trigger that I've seen, and it's more and more frequent. And that's going to make a big difference.
Well, I really would like the luxury to say I'm only going to take funding from Black-led or person of color-led foundations, but unfortunately, it's only
I agree with you. Well,
white people who are saying that to us, but it's still it's very, very good. But yeah.
So we're at a point where we're supposed to go into question number 3, but we've already started to touch on it.
there.
And I'm going to suggest that we just continue this conversation with the issues that you raised, and Mireille raised one in the chat. I want to make sure that, and Shoshana mentioned the same thing about closing the loop. Mireille, do you want to pose your question?
Yes, thank you. I think Ngozi was getting to that point about engagement of the community members. There's a point at which in the work that we do, we see that community organizations, CBOs, they're willing to try. It can work for their engagement model to be on those platforms to exchange data. But it's time consuming, and sometimes it doesn't get them the results that they expect, or it's a little bit more complicated to sort out the workflows. And so I'm really curious to hear the Camden Coalition. You have developed a model where it's highly centralized, but you take a completely holistic approach. So, during the presentation you mentioned you were able to even work on funeral and moving remains and so on. So how do you keep this kind of partners, all kind of partners engaged, and how do they continue to play by the rules, the rule book of working in your coalition, documenting the work that they do, giving, closing the loop on referrals in particular?
Thank you for that. So it is a challenge. So Kathleen, for example, the last time I checked so we use Aunt Bertha, for example, as a community resource exchange, right? And Kathleen, correct me if I'm wrong, the closed loop referral component of that, I don't think is necessarily active. That's something we're trying to build towards, but that's a functionality that can exist within these platforms and that certain community-based organizations have as far as referral tracking. Many organizations track that manually. I think it has to also do with accountability as well, right? Like, so if you're working a set of cases, you're maintaining, relationships with those clients, and you're keeping tabs of those referrals. But I think there's technological tools that we can use, and certainly these community resource exchanges, managing referrals is a huge issue. And I'd love to hear if there's other groups on this call that have figured that out, if they're using a platform or technology. All right, so we have pilots out. Yeah, exactly. And I would say, as far as community linkages, that is the work of community-based organizations to keep, and some organizations we have strong ties with, some we have weak ties. Weak ties are not necessarily a bad thing. We leverage them when we have to. There are some of these folks, Kathleen, the organizations that we work with in the region aren't necessarily members of the coalition, but when you're a community-based social worker, nurse, community health worker, peer, you're part of your trade is knowing the organizations in your community, knowing the contact folks. Oh, if I need to get something done, for example, when we had to repatriate remains, we work with a local community-based organization that services the immigrant community, because this is something that is actually done. We didn't make this up. We tied back into an existing network, an existing service. And a lot of times it's not necessarily us doing it, but we're making those linkages. So I hope that's helpful. I think the referral tracking is a big deal. And I know, and because it's key in care coordination, because what you're doing a lot of times is making a referral, and two pieces here. Is someone getting an appointment or a referral, and is that referral being executed, and is it actually having an impact? Is it a meaningful service as well?
Since 2007, we have run a monthly care management meeting for anybody that wants to come in the area. And it's open to care management, social work, nurse, medical assistants, anybody that just wants to come and network with other people who are in that coordination role. And, pre-COVID, you could have 40 or 50 people at that meeting on a regular basis. And it was a way to network. It was a way that new businesses would sometimes come in and say what they were doing. But that's been going since 2007 on a monthly basis, right? So there's just a lot of on the ground networking that we do. We also just started out and made a lot of what we did free. We have really pushed out our foundation funding to our partners. So they know that about us. So, we got funding from Johnson & Johnson recently to do work on behavioral health. We are pushing that out to our partners so that they see us as a resource. And that often comes with flexible patient dollars. For one of our local hospitals, they give us $25,000 a year just so they have this one department that needs a stash, has patient dollars that can be used flexibly, right? And then we sort of service that for them. Jason, I don't even know if you knew that. It's these little nuggets I find out about the coalition. I'm like, oh, I didn't realize we did that for that hospital. So yeah. We do a lot of things like that.
And you might be asking, what could we use that for? I'll give you an example. If someone needs a ramp built or a mold remediation, that there's no other funding source, we have these flex funds that we could use. Or if there's an infestation, or for example, if they need support in repatriating remains, we need to help them out. Now, some of that is covered under insurance, but I'll also say too that networking helps you, right? And I'm just thinking as you're mentioning that, I'm thinking about the connections that I made through, and this is the local work, Kathleen, I appreciate you mentioned, of knowing your geography, of knowing the players, because for example, I'm thinking about this hospice eligible individual where no one else would pick up the phone, but we called this hospice connection that we had, and we got this person to go the street into inpatient hospice, and he died with dignity. And then we all celebrated at his funeral. And that, having those connections, we were able to really get it. There was urgency, and we were able to get it expedited and get the person into care. And that was just based on the relationship. It was based on knowing the right person to call. And that's like kind of the deep work that happens in the community that goes unrecognized. And Kathleen, as you know, we have to struggle to get paid.
So we have 8 minutes left before we need to move to sort of summarizing the takeaways. So I wanted to give the group other burning questions for Kathleen and Jason around anything that we've talked today that you think is crucial to helping New York City to build its coalition. And if not, I do have a question. So I'm going to go to my question. So how, you've talked about looking at outcomes of individual patients, but how are you measuring the progress of the whole coalition's work?
Mm-hmm. Well, I mean, this is like such a CEO answer, right? But like, it is, but like, and Lisa, you probably, but like, first of all, am I going to make enough revenue this year to hit my expenses? I mean, are people buying what we're selling, right? I mean, that's like really, really important. But also, do we have more partners that want to join us? We look at influence, and, we have more people joining our HIE in the past couple of years than we've had in 5 years, right? In the 3 years before that. And that's because a combination of our national center and our RCT results really forced us to be full on. Like we got to spend more time building outside of healthcare, right, than inside of healthcare. And so we figured out how to help our behavioral health organizations use our HIE, where their data doesn't have to contribute, but they can get notices that are important to them, like somebody was in the emergency room, right? Or we now have our housing shelter, our biggest housing shelter on our HIE. Not everybody, and we're very careful about what they can see, but we're just much more focused on those ecosystem pieces. Mm-hmm. And because of that, I mean, before COVID, we made a push, and again, no one gave us money to do this. So I'm a little Thelma and Louise, and I tell the people at the state health department all the time, I'm going to see them in bankruptcy court because I have some outstanding invoices to them. But that's my lawyer sense of humor, sorry. We're taking leaps. And so a few years ago, we saw that the skilled nursing facilities were not within our HIE, and the health systems were not connected to them. And so, we had all of these skilled nursing facilities in our HIE when COVID hit. That was really important to our partners. And this thing that we did a couple of years ago where they were like, oh, okay, whatever, was suddenly really, really important. Mm-hmm. And so we're trying to think like that, to think about what's important to our partners and not just what's important to us as an organization. So I hope that helps.
Yeah, and Gozi, you've got a point in the chat about the socio-ecological model. Do you want to comment on that as it relates to this discussion?
Yes, I would like. Much of what I'm hearing speaks to the socio-ecological model, which the CDC had promoted this and trained some of our community organizations when we participated in a project called Racial and Ethnic Approaches to Community Health. And what it did is that it gave us the value of working not for a silver bullet solution, but on working with the whole person, the whole family, and then the community, so that community engagement, engaging service providers in the community, as well as the policymakers, as well as institutional leadership from the healthcare and other places, a wide cross-sector engagement, including the financial sector, because so many influences really affect the physical, mental, spiritual outcome of a client. And the healthcare system had focused mainly on clinical, and everything else was an adjunct and perhaps a maybe. So with this model, the Kaiser Permanente did a policy paper on the impact of that approach to handling community problems and engaging community members with valuable, meaningful engagement as equal partners, which I heard Josh talked about, Jason talked about. And so I would urge that anyone looking to address the COVID and the Black Lives Matter movement has really shown how inequities at every level of the system is a major driver. And if you use the socio-ecological model, you would address the inequities as a major systemic problem. One of the things I want to say is that as a community-based organization, we are always asked to come to the table to contribute and to share our intelligence, but nobody wants to pay for the intelligence. We told its value, but we don't have funding. We squeeze money from funding to do other work. And community members are also asked to do the same, and that value is not recognized. Everybody else who comes to the table comes with a paycheck for their time, except
Yes,
for
I
the
am. Are you
community
downstairs?
members. So those are some critical pieces that they, when you look at the socio-ecological model, that gets engaged in planning to address community health problems.
Thank you. Yeah, really, really important points. And I'm wondering, Jason and Kathleen, any thoughts you have on those issues and how you've dealt with them?
I think Ngozi said it well. I completely agree, and I don't think we do it well enough. And I think this is part of the major shift in being inclusive, sharing resources and power with our community-based organizations, and looking to uplift their voices and leadership. And that is an active process. And I think with the health and back to some of the initial themes we were talking about, we have a long way to go. And I think by design, if we get to design, it's also great design too, that you're leveraging local resources, you're empowering, right? You're building capacity, and to this point, like that is valuable and meaningful and is not tokenized. So I really appreciate those points, and I completely agree, and it's something that we're actively working for.
Great. Yes, thank you for that. I'd like to suggest that we move on and maybe go around each person and ask, what's a major takeaway that you've had from this discussion that we could hold on to? And Ngozi, maybe you could start us off.
Well, trust for me is a big piece of all the models I've heard about this morning. And it is important because as we see with the pandemic and the vaccine hesitancy, trust across the board is a major trust, and inadequate information and fears resulting from that. If anything, the pandemic has showed us a lot of stuff that had been hidden under the covers that is really important to community health and wellness. We have seen from going out to the community with what we call trusted messengers, just to discuss the vaccine and discuss the COVID and reaching people where they are with the information they need and recognizing their fears as valid and letting them know they've been heard has opened the door to maybe from, I don't want the vaccine, to maybe I'll consider it. And I'll take it. And if nothing else, I think COVID is a good place to start thinking about how we need to change the system. So trust, for me, being able for people to feel, one, that they're being trusted in what they say to be heard, and two, feeling that they can trust what they hear. And in this age of so much misinformation, it's magnified the need to have what you call trusted messengers deliver information to those who are most at risk.
Great, thank you. Abby, you just made a comment in the chat. Is that your takeaway, or would you have other takeaways?
Well, I think I have another takeaway hearing Ngozi just speak, and as you might imagine, a lot of my time has been spent on the COVID response in the last year plus, including just recently, I'm working at one of our vaccine hubs, which I've been doing routinely for a few months now, and working directly with clients who are coming in. And I cannot overemphasize what Ngozi said, and really, you know, speaking to the individuals that we're trying to reach, and all the different varieties. And this is one of the challenges in a place like New York City, that there is such incredible variety and variability from neighborhood to neighborhood, block to block, of what that looks like. And I think that is an inherent challenge, but it is essential. It's foundational to the work that we're doing, and that we have to really take on that challenge to understand it and take the time to understand those needs and who are the individuals that folks will listen to. I think we've hit a point with our vaccine response where, you know, people who wanted this and were ready to do it have done it. And now we've seen tremendous drop off. We've made great progress in New York City in the numbers who are vaccinated, but we know there's still a ways to go. And so I think that's a very here and now example that's really in the front of my mind, that really applies to what we're talking about. And how do we take the principles that were laid out so beautifully in such a short time by the three sets of presenters earlier, and really translate. I think that's for me, that the researcher, the theorist in me intersects with the practicality of how do we apply that in the real day-to-day work that we're trying to do, that meets the needs of individuals and communities, but also is grounded in what we know can work, but also acknowledging we don't necessarily know it all, that we need to bring the community partners in to really teach us and say, yes, all that theory and research serves well, but only up to a point. And so how do we really acknowledge that up front? Because I think that helps to get at trust piece, that we say we don't know it all, even if we think we do it and we're in these positions of power. So I'll stop because I want others to.
Yeah, we're going to run out. We're going to get cut off at one point, but thank you for, and Abby, do you want to quickly, oh, she jumped off. She put her takeaway in the box, but thank you for the resources you shared in the chat as well. Sure. Shoshana, what are your thoughts?
Yes, I have many. I'll try to be concise. I think that, you know, New York City is fragmented. The themes hit on by the presenters and in this discussion are common. The problems, the barriers are well understood. The technology that we need, the user experience for community health workers and not the non-clinical community rooted people who need to engage and also tether back to systems, has to be a user experience that is manageable. So when we hire community health workers, we cannot overwhelm them with the data management requirements of the payer, the health system, the city public health department, the checklists and the screens. We can't go past that tipping point where we undermine the ability of the frontline worker to connect as a human to the other human on the other side. So I mean, I've got to get more concise about my talking point there, but user experience with the right tech-enabled tools that have, you know, flexibility in them. Part of trust is like getting that person in the front line everything they need to just be able to connect. And right now we're really working against ourselves with all the prescriptive, like top-down stuff and requirements from everywhere. I know you guys know all of this. I'm preaching to the choir, but that's my thing for community health.
Thank you. Thank you. Really important. I'm going to go to Anne. Or Heidi. Is it? I don't know if Anne's on. Heidi, do you have any takeaways?
Sorry. Yes. Hi, I just froze up. I'm having internet issues. Apologies. This has been such a great discussion. And I think a big takeaway that I had from the session was Ngozi's point about racial diversity and leadership, and even thinking about and discussing models and approaches to the New York City environment. I think it's really important that we really hear from Black and Brown people and organization leadership. And so making certain that our continued dialogue is one that's more racially representative, I think is really important. But this has been great to hear more about the Camden model, and always lovely to hear from my friends and colleagues there.
Great. And Scott, I think you're still with us.
I'm here. Yeah. Sorry for all the technical problems I was having, kept going in and out. But I would say my main takeaway is just the frustration around the technology conundrum. And I think we have technology companies in this country that are the most powerful companies in the history of the world. And we have the smartest tech people in the world working on how to keep people addicted to social media apps. How can we demand that they turn their efforts to help us with these health equity questions that we're dealing with? Because there is a technology solution out there that could make all of our work a lot easier, a lot better coordinated, a lot more seamless, and make the patient experience a lot better, as Shoshana was saying. But I think we need to demand that these companies that have made trillions of dollars off of our attention and off of the advertisements that we're clicking on really pay attention to these health equity questions.
Thank you. Abby, you had another thought?
No, maybe I hit the wrong reaction. I was
Okay.
clapping to cheer
Sorry.
what Scott was
I
saying.
mean-
Maybe I did it wrong. I'm not.
Nope,
I'm-
I may have read it wrong. Great. So I'm now going to give PHS people the opportunity for takeaways. We've got about 2 minutes, but so it's not much time. But Lisa, what do you think? You're muted.
Mireille, I just wanted to ask you, who were sort of taking notes on both successes and challenges, if you have those available for us.
I can share my screen.
Great.
And I will show you. It's if you guys can see, and then I'm sure you already have all of that, but I was organizing it as part of the questions. So key designs, the key takeaways, the trust components, there are a number of successful approaches that the Camden Coalition mentioned. The challenges being healthcare, focused on how you've tried to address them. For question 2, operational approaches, there was lots of talk about engagement, client consumer representations, and the roles of organizations. Question 3 around data, the user experience with data sharing needs to be good. Tech companies should be lobbied. That's not what Camden said, but I think that was behind, between the line you talked about. The need for interoperability and getting an HIE in place, the need to engage the vendors in this conversation. So that's what I took from these conversations.
And if I were just going to share mine around the technology piece, I think is pretty clear. On the first thing about what I found really fascinating in this discussion was the role of the Camden Coalition as the convener. A huge amount of work around building those relationships over what appears to be an extraordinarily broad set of organizations, but also cultivating the right relationships, a win-win situation with hospitals and payers. And I know that's taken some time, and our work is at least earlier in that, but kind of get the right people in the room, make sure those voices are listened to, and sort of provide the support for this to all be constructive in the way people are working with it, as opposed to, when you're starting, it just seems like everybody has a different agenda. Okay. And it seems
I want to say, they're about to close the room. I just want to suggest that one thing that's missing here is the issue of diversity and leadership.
Yes.
I think we don't want to lose that. And so it's maybe one of the challenges that we have under question number 1. I think we really have to tend to that. I'm sorry to cut you off there.
Nope, makes sense.
Okay.
Just in time.
We're
Diana, beautiful.
Just in time. Thank you all very much. Very interesting discussion. Thank you.